Let's talk pulmonary edema, and more specifically, let's talk congestive heart failure. So, CHF, congestive heart failure, is just a failure of our pump function, the pump being our heart, and loss of our Starling forces. So, we think back to our Frank Starling law, your loss of our Starling forces and within our pulmonary system. So we're talking about pulmonary edema within our pulmonary system. Now our osmotic pressure, our pulling pressure, is less than our hydrostatic pressure, our pushing pressure. So if our pushing pressure, hydrostatic pressure, is greater than our pulling pressure or osmotic pressure, if I'm pushing out of the vasculature more than I'm pulling into it, so they're not equal, I'm pushing into our pulmonary space. We're third spacing, and we are creating pulmonary edema because of congestive heart failure. A lot of things can cause CHF. Just changes in medication can cause this fluid shift, can cause this pulmonary edema, this congestive heart failure. Obviously, cardiac damage. If we have a myocardial infarction, if we have a heart attack, an MI, that can happen. Cardiac dysrhythmias. If we go into AFib, we go into a ventricular rhythm, a junctional rhythm. We can cause CHF. Hypertension, valvular diseases can cause this, and our iatrogenic fluid overloads. Remember that iatrogenic means something that we caused, a medical treatment caused this issue. So if we fluid overload these patients, we can cause pulmonary edema, precipitate CHF. So as you're going through Dr. Braithwaite's cardiology courses, you know that if we overload our chronic cardiac patients, we can cause pulmonary edema just by fluid overloading them. We have a few classifications of CHF, classes 1 through 4. Class 1 is, you know what, you've got CHF, you've got heart failure, but you've got normal physical activity, no big deal. All the way through class 4, where you've got heart failure, but you've got all your symptoms, even if you're just sitting on the couch. So kind of good luck. In between, class 2 is you kind of normally exert yourself. You go up a flight of stairs, and you might have some fatigue, some shortness of breath. And class 3s are just going up that flight of stairs, just normal activity. Maybe even just walking down the hallway creates some significant symptoms. So class 1, no big deal. You've got CHF, but you've got normal activity all the way through class 4. We've gone through normal activity where you can't do any normal activity. You can't even walk down the hallway without symptoms, and you can't even sit in a chair without symptoms. What are some signs and symptoms of CHF with pulmonary edema? Well, we've got dyspnea, shortness of breath on exertion, or maybe not on exertion if they're into those later classifications. Maybe it's not on exertion. We've got orthopnea, big fancy medical word for, when I lay down, when I sit down, my shortness of breath gets worse. So I have a harder time breathing when I lay down. Same with paroxysmal nocturnal dyspnea, or PND, when I go to bed. When I try to sleep, I have terrible shortness of breath. So it goes along with orthopnea. I'm laying down when I go to bed, and I get shortness of breath. So your CHF patients, pulmonary edema patients, when they get a little bit more advanced, they might tell you that they sleep in a recliner, right? They're just in a lazy boy. They're in a recliner in the living room, and that's the only way they can sleep because they're sitting a little upright. Right? With our CHF patients, we're going to have pulmonary edema. When you listen to their lung sounds, it's going to sound wet. And they're going to have a productive cough. They're going to have a lot of kind of sputum coming up. If it gets to a frothy kind of pink sputum, we know we're definitely progressing into a bad situation there. In the hospital, they're going to not only do X-rays and patient assessments just like we're going to do, but we're going to do a little extra. We're going to look at some laboratory values. One is BNP, the B natriuretic peptide, or brain natriuretic peptide. BNP is secreted by our heart muscle when it's stretched to its max. So with pulmonary edema, And thinking to Frank Starling's law, we're stretching to its max. We're going to release BNP. Our normal BNP should be under 100. With these patients, it's going to be greater than that, much greater than that. We're talking 500, 600 into the thousands for the CHF pulmonary edema patients. Your BNP is going to be a little dependent on your age and your history, but anything over 100 is going to be elevated. When treating our CHF or pulmonary edema patients, our first line treatment is going to be CPAP or maybe BiPAP. And again, we'll talk about that later on when we talk about ventilators and different ventilator settings. Just about every ambulance you're going to come across is going to have CPAP on it. You might have BiPAP capabilities, but we'll just focus on CPAP. So we're going to throw them on CPAP. That's continuous positive airway pressure to keep our alveoli open, to push fluid from that interstitial space, from that third space, back into the vascular space. We're trying to equalize our osmotic and hydrostatic pressures again. We can also give nitroglycerin, so we're trying to vasodilate a little bit. We can give that sublingually, we can give that as a paste, we can give that intravenously. For your pulmonary edema patients, for your CHF patients, probably the first line option we're thinking of is as paste. So we're putting them on CPAP. We want them on that mask. We want them comfortable with that mask. We don't want to break that seal of the mask. So why would we give it sublingually? We have to break the seal. We have to take them off the mask every 5 to 10 minutes or so. Well, let's just throw them on a paste, right? We can put them on paste. We can put that on the chest. If our blood pressure drops precipitously, well, we can just wipe it right off. If you have nitroglycerin available IV, that is the best way to give it. We give it very, very in a controlled way. And again, if blood pressure does drop, we can just stop that IV drip. So with our CHF patients, with pulmonary edema patients, definitely recommend paste #1 or IV #1 if you have the comfort with it. If you have it available, paste is right up there with #1. But if you have to give it sublingually, we can break that mask seal to give it sublingually every 5 to 10 minutes or so. You can also give dobutamine if the pressure starts to drop. So pressure starts to drop, we're going into cardiogenic shock, and we really don't want to give dopamine, because remember, dopamine is going to put a stress on the heart. It's going to increase myocardial oxygen demand. Dobutamine is going to increase. It's a positive inotrope. It's going to increase contractility without increasing myocardial oxygen demand. So dobutamine is going to be your first line vasopressor, and I say that in quotations because dobutamine isn't really a vasopressor. It's just a positive inotrope. But that's going to be our first line. You can think about dopamine or Levophed. Kind of second line, they are going to increase a little bit of oxygen demand on the heart. But if you don't have dobutamine available and you're going into cardiogenic shock, you can go to other vasopressors. As we mentioned, nitroglycerin is the way to go. So we've got CPAP, and then second line is going to be our nitro with these CHF patients, pulmonary edema patients. Again, we can give it sublingually. Each tab, each spray is about 0.4 milligrams each. We can go paste. We can go 1 to 2 inches, and that dose is dependent on your patient's systolic blood pressure. We can give paste that's easily applied while keeping our CPAP mask on. And if our blood pressure drops, we can just wipe that paste off and kind of deal with that blood pressure. Or we can give it IV. We're going to start an IV nitro drip at 5 micrograms per minute. See how our patient responds to that, and then we're going to titrate up based on symptoms and blood pressure. We're going to titrate up 5 at a time. So we're going to go 5 micrograms per minute, and then titrate up to 10, 15, 20, 25, 30, so on and so forth. I've never really seen a maximum, a ceiling to nitroglycerin drips, but once you hit I would say like 50 or 60 micrograms per minute, you might be wanting to think of a different treatment modality. But we're going to start at 5. We're going to titrate up by 5 depending on our patient's reaction. If you have any questions, comments, concerns, or cuss words, please let me know.